All right, welcome to video 2 of Public Health 5101. So last time we talked about a general introduction to the field of epidemiology, and today we're going to talk about our circle right here, which is the measures of disease or outcome occurrence. So our entire class will be talking about the ways in which we quantify health and disease. So first of all, let's talk about why do we need to do this? Why do we bother? So there's a bunch of different reasons. Some of the key ones are to determine the extent of disease in a community. So, how much diabetes exists in our community? How much HIV? These are really critical questions. The second is to identify the causes of health indicators and factors that increase or decrease a person's risk for the outcome. So until we can start quantifying health, we can never take it a step further and understand what factors contribute to increases in disease risk or decreases in disease risk. And finally, to evaluate interventions designed to affect health-related states or events. So if we don't even know where we started with a health outcome, we will never know if our policies or programs or campaigns or whatever you want to call them, or whatever you developed, make any difference. So we need to have ways to measure the health of communities. So before we get started into our math, I wanted to talk about the concept of a population. And we started off this class talking about how epidemiology is about population health. Well, what do we mean by population? So, we're never or very rarely going to be concerned about or going to be able to study the health of everyone on Earth, right? It's too big a population, it's too diverse. Generally, we care about sort of subpopulations among basically all humans. And we define our populations by a number of different factors. So we often care about geographic spaces and time and how that limits population. So we care about the population of the city of Philadelphia, or we care about U.S. Residents, or we care about people who were born during the 1960s or the 1920s. So often geography and time limit or put parameters around the population of people that we're interested in studying. We also often in EPI are interested in populations defined by a characteristic, event, or exposure. So we care about newborns, we care about menopausal women, people who were exposed to a natural disaster or participated in a war. These are all characteristics that define the populations that we then go and study in more depth. And finally, some of our studies define their or identify their populations by considerations that are unique to the study. So a study may care about healthy individuals. They want to start with people who are healthy, who are engaged, who do well being in studies, with the idea being that if we can study that population of healthy, engaged people, it's a starting point, and then we can do future work to try and tackle the harder job of capturing people who are not very engaged in health research. Now, as you can imagine, these characteristics of populations are not mutually exclusive. So we often care about, people who experience a natural disaster who live, in Manhattan. So if we're, thinking of September 11th, there's a whole study of, tracking people who are exposed to September 11th. We may care about newborns in African country or any country. We may care about menopausal Black women because maybe we know some things about the role of hormones in menopause and health outcomes in white women, but we haven't done as good a job studying Black women. So again, you're starting to hear some of the language about how we identify populations. And as we move forward in our studies and our research, we're always going to say, this is the population that I collected data from. So that's basically who I can talk about when I talk about the occurrence of health and risk or protective factors for health. Okay, so an important characteristic of populations is whether they are stationary or dynamic. And we're going to introduce these concepts right now, and they're going to come back later at the end of this lecture when we're talking about specific measures of disease. So basically, a stationary population is one that does not allow movement inside or out. So once people are part of the population, they are always going to be part of that population. And that sort of the perfect example. We do a lot of our examples of food-borne illness outbreaks involve church picnics. It's kind of an epi joke. So, when we're trying to figure out what made people sick at a church picnic, we have a population of people who attended that picnic, right? And it's a stationary population. They, when we started our study, there were 50 people who were at the picnic. And when we ended our study, which may have been recording what they ate that day, we still had our same number of people at our church picnic. There wasn't a long enough time that people would sort of be lost to follow up, and we don't know what else they were exposed to. It's the same group of people who started in our population and ended in our population. So the alternative to a stationary population is a dynamic population. And this is one where membership is defined by something that can be changed. And thus movement occurs in and out of our population. So the best examples for this, I believe, are geographic. So, say the population of interest is Philadelphia residents, and you want to track them over 5 years and see how their health changes over that time. Well, obviously, you're going to start with a group of people who live in Philadelphia, and a subset of them are going to move out, and then a new subset of people are going to move in. So if you really cared about quantifying the health of every person in Philadelphia, you're going to have to figure out how to deal with, well, what do I do about the people who moved out, and then what do I do with the people who moved in after I started studying health? Similarly, sort of on a smaller scale as Temple students. You may be interested in the population of Temple students, but that changes, on a semester semester to semester basis. And so you need to think about, okay, how long did I track these people? How long were they part of my study? What happens? How do I find out about their health status after they've left Temple? And does that matter? So this stationary versus dynamic thing has a lot of implications for how we're measuring health. And one thing to think about with stationary versus dynamic is that it can happen on either end, right? So we can think about, is my population stationary or dynamic on the front end where I start my study? And then is it dynamic or stationary on the back end? And to be honest with you, most of the studies we do and most of the populations that we track, we end up with groups that are stationary on the front end. So we sort of say, okay, anyone who's a resident of Philadelphia in January 1, 2015, but then they're dynamic on the back end. So we can't control that people are leaving Philadelphia and leaving, essentially our catchment area for understanding their health. So just keep these terms in mind of stationary and dynamic, and we'll come back to identify some more examples of whether populations have these two characteristics. Okay, so just for a few minutes here, we're going to do a really brief mathematical review. And I do want to say before we get into this that I know a lot of students taking this course, you may be enrolled in the MPH in another concentration area, or you may be in another degree program entirely. And a lot of people come to me and say, well, I'm not very good at math, or I'm a little nervous about the math. I'm going to tell you right now that this is not high-level math. Basically, the most difficult thing we're going to do in this course is sum division. So if that gives you some, you can take a deep breath and relax, and we'll get through the math together. So I just wanted to review a few concepts that maybe you need to draw back on your high school math if you haven't taken statistics in a while or any other math course. So just first, I want to talk briefly about a few different types of variables that we often encounter in health research. And the two major types of variables that we tend to encounter are categorical or continuous. And for categorical variables, they take on one of a fixed number of possible values. So two types of categorical variables are binary, where the exposure or outcome is either present or absent. So you're sick or you're not. You took a medication or you didn't. It's binary. It's essentially a 0-1 if that helps you think about it. So that's a type of categorical variable. And to be honest with you, that's actually the type of variable that we're going to deal with the most often in this class. And it's essentially a lazy issue. It's a lot easier to do the simple math that we're going to do with binary variables. Is someone sick or not? Were they exposed or not? And you'll see as we go through this class, almost all the examples are of that. But that certainly doesn't mean that that encompasses the entirety of the health variables that we deal with on a daily basis. So just because we're dealing with binary variables most of the time of this course, remember that that doesn't capture everything. Often we have ordinal variables to measure our health. So these may be, if you've asked someone to rate on a scale of 1 to 10, you know, how would you categorize your health? And then you end up with an ordinal ranked variable. Another example might be servings of fruit per day. So you give someone a survey and you said, how many servings of fruit did you eat yesterday? 0, 1, 2, 3, 4, 5. What you're going to end up with is 0 through 5 indicator for that person, and that's ordinal. It's a categorical variable where the categories go in an order. And finally, a really common type of variable that we deal with in epidemiologic research is continuous. So within limits, any value between the minimum and maximum is possible. So you can imagine blood pressure, someone's viral load if they have HIV, a baby's gestational age. These are all continuous variables. And to be honest with you, in this course, we actually don't look at continuous variables very much because the math is a little more difficult. But again, just a reminder that they certainly do exist and we deal with them quite a bit. I mean, I deal with, taking people's BMI on a daily basis, and that's a continuous variable. But then I could create a binary variable from it where I say, is the person obese or not? Okay, so just to keep in mind those types of variables. So now moving on to a few other math concepts. So the first concept that I want you guys to be familiar with is the concept of a ratio. It's very simple. You all encounter it in your daily basis, on a daily basis. So it's basically the value obtained by dividing one quantity by another. And there's not necessarily a relationship between the two numbers. It doesn't have to be that the numerator is part of the denominator. So as an example, we have 14,364 women enrolled at Temple, 13,259 men enrolled in Temple. So we can create a ratio of men to women. As you can see, we can represent it as 1.08 to 1, our women to men, or we can multiply up. If we multiplied both of these numbers by 100, we'd end up with 108 to 100. And this is often what we do for ease of presentation. We don't like to present sort of, parts of people. So often I'm going to have you multiply up and say, okay, so per every 100,000 people, how many cases of disease there were. So you'll become really familiar with decimal points and multiplying by tens to move your decimal points. So a specific type of ratio is a proportion, and this is one where there is an explicit relationship between the numerator and denominator, and specifically the numerator is part of the denominator. Gosh, you guys, again, must encounter this on a daily basis. So our example here is that of the 27,623 students at Temple, again, 14,364 are women. What proportion are women? So we can divide our numerator by our denominator. Remember, our 14,000 women are in our denominator, and we end up with 0.52. So 0.52 is our proportion. I want to point out here that a couple of things. So here you'll see the leading 0. I think it's a really good habit to get into to always put that 0 before the decimal point, because then you can always make sure that you actually meant to have a 0 there and you didn't just forget to put some other number. The other thing is that in general, for this course, I think rounding to the 100th place is a good habit. You don't end up with a completely unwieldy number, but you're able to get enough information. You're not losing information. So that's something to, unless I say otherwise, generally you're safe rounding to the 100th place. And then we can move on from our proportion and actually turn it into a percentage. And that obviously is just your proportion multiplied by 100 to end up with a percentage. So in this case, 52% of Temple students are women. Hopefully that's an easy enough example. Okay, and then finally, the concept that I want you guys to be familiar with is the idea of rates. And a rate is a type of proportion where a unit of time forms part of the denominator. The rate you guys are probably deal with on a daily basis is your miles per hour. I went 50 miles per hour. You always have to have a part of time as a denominator. Some health examples where you might see a rate is that, say in a population there were 20 pregnancies per 100 women per year, or 5 cases of depression per 1,000 people per year. This is really important, that you're often going to see the word rate in epidemiology where we're not actually discussing a rate. I try to be very, very careful because I think it's really confusing that we call a lot of things rates that aren't really rates. But you'll see it's just sort of commonplace to call something like a mortality rate, which we're going to learn next week, as a rate, and it's not actually a rate. So just be wary of that, and as you become more familiar with those things, you could sort of laugh at those people that make those kind of mistakes. Okay, so the last thing I want to talk about with this first video of week 2 is the idea of a count. Again, we are going to very simple math concepts here, and hopefully you all are comfortable with this level of math. So in epidemiology, a count is the number of persons with an attribute without reference to the number of people examined. Okay, complicated explanation. You're basically counting people. So you may go to a school and ask the kids how many people wear a bike, how many of you wear a bike helmet when you ride a bike? Or you may be investigating whether there's a foodborne disease outbreak, and you figure out how many people got sick after eating at an on-campus restaurant. These are all counts. You're just going to end up with a number. You're going to end up that within a certain school, 500 kids said they wore a helmet. Or when you go to this restaurant on campus, 100 people said they were sick yesterday. Just a very simple number. And the counts may be sufficient for some purposes, right? Even though it's so simple. So a count can be used to identify the beginning of an outbreak or an emergence of a serious health condition. We can think of, the ideas or the health outcomes of, again, Ebola or measles or pertussis. And to see one case of that is concerning because it's such a dramatic health outcome that we really need to mobilize public health efforts to deal with. So it doesn't matter that it was 1 out of 1,000,000 people who ended up with Ebola or who are showing symptoms of Ebola. One person is serious. Counts also help determine the need for healthcare resources. So again, you may know in a community that 50 people are diagnosed with HIV, and that will give you some sense of how many, physicians or clinical care units you need in that community to deal with that many patients. It doesn't matter that if it's 1% of the population or 50% of the population, you need to serve 50 people. And also, finally, counts can be useful in helping us compare the number of cases in the same to compare the number of cases in the same population from year to year, assuming that our population stays steady, right? So the idea here is that, if the population of Philadelphia is going to be very stable over time, and there's generally 1.5 million people who live in Philadelphia, then you can look and see, oh, this year we had 100 cases of measles, and next year we had 200 cases of measles. You don't necessarily need to know the exact number of people in that population. They don't need to know a denominator. Knowing the number of cases is enough to know whether things are going up or down. All right, but what's the problem with cases or with counts? So this is a funny comic, I think, to elucidate that. So, if someone were doing market research and they found that, what's the count of people using our website? Oh, look, there's some hot areas here on the East Coast and then, around Chicago. Okay, so we know who's using our website. Oh, look, we also, have high counts of people who are subscribers to Martha Stewart Living. And then also high counts of people in these same areas who enjoy a certain type of pornography. It would actually be a pretty poor businessman to think that these are all related, because the truth is, right, that these hotspots are just picking up on places with high population. So of course you're going to get a lot of people who enjoy this type of pornography, or of course you're going to get a lot of people who subscribe to Martha Stewart Living when you have high population density. So what this is pointing out is that there's a really limited use for number of counts. We need to know our denominator. We need to know how many people are contributing to these numbers to start to get a better sense of things. Okay, so as I was saying, the problems with counts is that they really limit comparison across populations. Having 100 cases of a disease among a population of 1 million is very different than having count 100 cases of disease in a place where a population is 500. We can't compare what's going on in terms of health in those two areas. So for that reason, counts are not that useful. And in the next short lecture, we're going to move on to learning about prevalence and incidence, which provide us much more useful information about the state of health in our communities.